Good morning and welcome again from Mount Sinai. This is Raman Sharma along with Dr. Karthik.
Good morning.
We'd like to first congratulate all of our team and thank you all for joining us for our latest New York Endovascular Summit held here in New York, which was a fantastic success. I think we all had a really great time collaborating with all of our colleagues in vascular surgery, podiatry, all of our nurses and techs, and all of be from our venous side as well. We had a tremendous fellows course, and this was a fantastic turnout. And we're looking forward to also inviting you. It's never too soon to inviting you next year to our New York Endovascular Summit on October 10th, 11th, and 12th. Oh, that sounds like we changed the date. Big, a little hiccup.
Venue. No, we had a hiccup with the venue. Sorry to cut you off. I didn't want to give them the wrong dates. So we had a little hiccup with the venue. And well, first of all, good morning, Karthik. Good morning, Raman. I'm sorry I didn't say good morning, but great to see you guys. Very, very nice looking both of you today with the wonderful suits and ties and good haircuts. But Vishal and I are here working while you two are looking good. But all kidding aside, Raman, the dates have been changed to the second week in September, not the week after Labor Day, the week after that. I forgot if you could look it on your phone. It's the Thursday, Friday, Saturday, Sunday. But this time, what Raman we're going to do is we're going to do the fellows course on Thursday. And then the main course meaning all the
14,
main courses
15,
on,
16.
yeah, 14, 15, 16, exactly. So we'll be terminating, Thursday,
September.
Friday, Saturday.
12, 13, 12, 13, 14.
No.
No, you said September, correct?
Yes.
Yeah, so 12, 13, 14.
Perfect. So 12th, 13th, 14th of September, 2024. It's going to be at the Marriott Marquis, as both of you know, and we're very excited to change the venues. But we had a fantastic turnout. Over 500 people came with over 80 fellows. Incredible job with the cadaver lab and all the fellows teaching, as well as live cases from Dr. Schmidt in Germany, Dr. Metzger, our very own Dr. Kapoor and Guja in New York, and then we also had Dr. Saab as well as Dr. Hinau, all sending incredible cases. Discussion was robust, and I thought the faculty was incredible. So we look forward to all of you coming next year. And, I just want to introduce our team. To my right is Dr. Vishal Kapoor, who is the associate professor as well as director of endovascular services of Mount Sinai Morningside. Behind me is Ray Lascano, our interventional nurse practitioner, endovascular, I should say, nurse practitioner. To Vishal's right is Dr. David Song, one of our two fellows. Behind him is Avi Khan, our wonderful nurse, and next to Avi is Jen Curiel, our other wonderful nurse. In the room helping us is Damian Cabrera, excuse me, and we're ready to start. So before I start, I just wanted to tell you guys that we have a very exciting case, Karthik and Raman. This is a case that's a little complicated because of rising creatinine. So we have decided to go with carbon dioxide. And we've also decided to use IVUS to guide majority of the intervention. We do have a diagnostic angiogram from a prior intervention that we're going to show, and then we'll discuss how you tackle these cases with rising creatinine and how carbon dioxide and IVUS may be used. So, David, you want to present the case?
Yeah, sure. Good morning, everybody. Thanks for joining us today for an excellent, complicated multi-level intervention case. So this is a 63-year-old gentleman. He has progressive bilateral lower extremity lifestyle limiting claudication that's progressed to rest pain with the right lower extremity non-healing wound, Rutherford grade 3, category 5. He's on good medical therapy. He was with good supervised exercise therapy, but he persisted to have symptoms and developed this wound. His ambulation is limited. And of note, this patient is actually here visiting his daughter and was noted to have a previous intervention a couple of months ago outside of state with the right SFA stent and also right toe amputations. He has multiple comorbidities, hypertension, hyperlipidemia, diabetes. He is a polyvasculopath. He has CAD status post CABG with subsequent PCIs. And like I mentioned before, he has had previous interventions and also toe amputations. He is a current smoker. Given his extensive CAD, he is actually on Brilinta and Eliquis for his Afib, and he's on good medical therapy. We don't have any non-invasive diagnostics. He is from out of state. We weren't able to obtain those records, but on physical exam, he did present with his non-healing right toe wound. And in terms of the pulses, his bilateral femoral pulses were palpable but diminished. Bilateral DP pulses are Dopplerable. Bilateral PT pulses are absent. He has superficial skin changes consistent with severe PAD, bilateral lower extremity scaly skin, sparse body hair, and he has bilateral poor nail formations and also loss of nails. We have had a previous diagnostic angiogram. The first shot is of the lower extremity runoff. He has diffuse fin pop long lesion calcific disease that extends to below the knee. The second shot right here just shows the left-sided runoff, and he is known to have about 2 vessel runoff, and he has disease in the peroneal as well. In terms of the aortic ileogram, he does have left-sided external iliac disease that is also calcified, but before we went live, we did a pullback gradient. It was not significant. In terms of the right lower extremity runoff, you can see the kind of mid-distal SFA stent, which is actually intact. There's no ISR, but there's actually proximal and distal to that stent. He has de novo lesions, and he has below the knee disease. This is the last shot is just of the right lower extremity below the knee runoff, and he had a significant disease there as well. So we actually initially intervened on the right lower extremity given the non-healing wound ulcer, and this is the post-intervention of the below the knee. The peroneal and the PT are revascularized with good flow.
Stent because I don't want to put a stent. So the right foot is doing well, but what's happening is his creatinine is rising, Karthik and Raman. So we brought him in. We did a CO2. We did actually first we did a regular angio of the groin, which is horrible, and then we went ahead and did we didn't do an iliac pullback gradient of the iliac, showed no significant gradient. Even though if you look at our cuff pressure now, you'll see that it's damped. His excuse me, our aortic tracing is damped, but the cuff is fine. So let's go to the IVUS, guys. So we wired the posterior tibial down into the foot. And then we did an IVUS pullback. Go live, guys, on the IVUS for us.
Can you go back
and
play?
Vishal can describe the IVUS would be great.
Yeah, so can we go all the way to the beginning of the recorded IVUS, please? Yes, please. Let it play. So like we get
from the peroneal, okay.
Yeah, so we start from the posterior tibial in the mid segment. You can see the circumferential calcium right there, significantly calcified, but as we start pulling back, you're going to see a lesion right at the proximal AT, which corroborates with the right there. Sorry, PT. So you see that right there,
the ostium.
Right at the ostium, we stop, and then it goes. The disease actually extends into the popliteal, and you're going to see the popliteal PT size is around 3.0, and the popliteal starts to grow up in 4. But look at all the disease and the plaque burden right there, and then you have a sort of normal segment. But again, there's a lot of disease coming up. Here, that's the normal segment we're talking about, but then you're going to see the plaque buildup right there. And as we scroll down, there are multiple areas in the SFA which has significant disease, both plaque and calcification. So here, look at that. So the plaque, it's concentric plaques. This is mostly in the distal SFA. And we keep pulling back. There is calcification and the plaque burden right there, as you can see. So it's a mixture of both plaque and calcification with some nodules as well.
But there are areas of severe calcium.
Correct. So we're going to pull back more, but as and how the run goes up, you're going to see multiple layers, multiple lesions at different areas of the SFA. So right there. So the disease definitely extends all the way up proximally. And that's what it says. So see that calcification right at 12 o'clock. And then we're going to pull back. Look at that dense plaque again.
Plaque, fibrocalcific plaque over there. We've marked all these on the SFA, but it's pretty diffuse with areas that's kind of relatively normal.
Right.
So that's kind of the challenge with us with these difficult SFAs. I'm just going to do a couple of CO2 shots of the SFA for you so you guys can see what we're dealing with, and then we'll take a look. I mean, obviously CO2 is not the best, way to visualize, but we went with IVUS, and just for education purposes, we're going to do CO2.
So a question for you guys.
What's your settings?
Given that we have IVUS images of the entire vessel from the PT all the way up to the proximal SFA, how is that going to be used for you to decide your adjunctive therapy here, as far as your atherectomy or whatever that you may use?
So that's what we want to talk to you guys about. Obviously all of us are quite busy. We do a lot of different work. So Karthik and Raman, if you see this, Vishal and I were talking about it offline. You see, you've got this proximal tight lesion around. Ray, can you go to Oh, actually, you can't go. Freeze it for me.
No,
You can't go to non-subtractive.
We can.
No, go to freeze it and freeze the image.
Hold on.
With the full.
1 second.
Okay, right there. Stop. Okay, good. Now you got to freeze it. Though. I don't want it to run.
Okay.
So right around, I would say 30. You would a little bit more, right? Step it a little bit. I don't know if you can see it, Karthik. Right above 30, right by the lesser trochanter, you got a tight lesion, right? And then that segment is lesion, and then play it forward a little bit, Ray. Then you see anywhere from, so IVUS was very severe from 20 to 15. Correct. Very severe. I mean, 20 to 10 almost. Extremely severe eccentric calcified plaque. And then next. Oh, okay. So, and then you can see the distal is left. Now I'm going to show you the pop as soon as Avi moves. I don't want to inject Avi.
Are you injecting directly from the sheath, or are you going to take a catheter down?
Well, right now, since we have the IVUS, Vishal and I are very convinced of what's going on here. Yeah. So we're going to just do one shot from the sheath. I think you'll be fine. Below knee, there's not much as you saw in the prior runoff. Forgive me for making
you have prior angiograms anyway, so it's okay.
Right.
Exactly.
Just one shot from here, right? So you're going to see it here. So as it comes down, and Vishal's a very strong man, as you can see, good injection, right up. I probably didn't get down far enough. That's a very good injection showing you the pop doesn't look bad interventionally. And the question is, how do you assess these patients, right? So the idea here is now, if you, one of the things, don't move.
I know it hurts.
I know it hurts. Okay. We're going to flush it out here. Give him a little moment.
Yeah, you can probably dilute it a little bit. Yeah.
No, we'll get him a little bit breather for 1 second. Okay. No.
Okay, hang on, my friend.
No more.
That's the only downside for CO2 is they get the burning.
No. You're doing great.
Well, the distal pop you saw. So we're going to just do a quick IVUS. Flush it for me. We're going to do a quick IVUS of the distal pop. It looks right in the area of the bifurcation into the posterior tibial.
Around 21 or so.
Yeah.
So if you go C minus here, Ray, for me. So the idea is, what do you guys think about us putting a pressure wire and doing a pressure wire gradient, pulling it back, and then deciding which of the segments we need to treat? Or do you think the other thing to do is to treat the segments we think we want to treat, then put a pressure wire down and see if there's any gradients that we missed?
So first of all, what's the status of the foot on this side?
This side, he has no wound, but he has a severe claudication and severe rest pain of the foot.
Mm-hmm. Okay.
Because the AT is out, the perineal's out, the posterior tibial has a tight osteal lesion. So when he starts to walk about 50 feet, he gets pain in the foot, and then it radiates up, and obviously he has calf claudication as well. So we feel that we should fix multi-level, because without fixing the outflow, we're going to be in issues. So let me just tell you, as you guys talk, Vishal and I kind of decided what we want to do. So what we're going to do here is we're going to do a directional atherectomy of the distal pop into the PT, followed by a serenator. And then we're going to do Shockwave of the mid, and then we're going to do it. So I want you guys to tell me how you would size the the Shockwave and the serenator to prevent dissection. Because the last thing me and Vishal want is a full metal jacket with this runoff. Back up.
Right.
You give another 5
Go
minutes.
for it, Raman. Go for it.
Yeah. Clearly, if you're going to be going down to this distal of a size, even in your IVUS, it didn't look like this was more than like a 4 millimeter vessel. So even like an EXL, generously 4 cuts if you want to with an EXL and the distal pop, and 1 in the PT, I think is very reasonable. And using the same 1-to-1 size for the serenator should be okay. Just to provide a little more of a different approach. How would you feel about doing CSI for the entire length of this, using the same device for everything? Do maybe like a 125 for the PT at low speeds and do a little bit higher speeds?
I think the only problem with CSI here is embolization. I mean, you have to put a filter
with a 2.4
with the high creatinine. We are limited the amount. The reason why I think atherectomy will be a problem here, extensive atherectomy. Actually, ideally, it would be perfect to atherectomize the whole segment, as you said, and DCB it. But here the problem is the creatinine is high. You don't want any embolization, and CO2 is not reaching the bottom of the foot, and he's not tolerating it. So I think the plan what Vishal had, I think, is great. Focal atherectomy of the tibials and the popliteal, Serenator is fine. I don't know if Shockwave really has a major role in this.
Okay, stay.
I think it's fine. The vessel itself is there. I think it's all atherosclerotic plaque. I think DCB, long DCB, probably a focal stent in the proximal SFA would probably suffice. I think just to keep the cost down.
Vishal, what can you comment on? I think Raman's had a great idea. I think Karthik has a great idea.
Yeah.
You know, so what do you think about Raman's idea about CSI? What are your thoughts?
Well, again,
how do you do this?
I mean, you're right, Raman. I mean, the CSI here, a 125 would well work for the popliteal and the distal pop in the PT. But the one thing that I clearly agree with Karthik is if there's distal embolization, then we would not really know. As you know, the CA2 doesn't really go into the tibial, so we might have to use a dye in it. And if there's an issue, then we are chasing our tail. So now to be a little bit more conservative, I think from the atherectomy standpoint, probably do a directional here which we can control. And whatever luminal gain we don't get, we're going to balloon it with a cutting balloon as well. See how PK is even trying to get it across, and it doesn't go. So I think
it's absolutely incredible to me.
This is a 3.0. This is a 3.0 Serenator.
Yes, it's a 3.040.
So a little bit of love it went, Raman. Like you always told me to love the devices. So a little bit of love it went. So go C- here, guys. So what?
I will say one thing. I don't think I entirely agree with the idea that you can't see it with CO2. I think it's going to take unfortunately just the extra step of going down with microcatheter with like a O35 catheter and then have a co-pilot. I think you can. It just adds a lot of time.
And also I think he's not tolerating it. He's having so much burning, and I think if he has embolization, there's going to be a lot of stalling of CO2 in the vessel. And he's going to burn him a lot.
Guys, 1 second. Vishal's going to describe this balloon. A lot of people don't know about it.
Yeah, so this is a balloon which is a new cutting balloon which has longitudinal stainless steel wires, 3 of them, which are lined around the balloon. So it cuts it. The idea being here, so the recommendation is to do 4 atmospheres for 1 minute and then go up to 6 atmospheres for 1 minute, thereby creating like controlled micro dissections all around the plane or circumferentially of the vessel, and hence increasing the luminal gain and the elasticity as well. So that's how it usually works. So of course we size it 1:1 like any balloon does, but this is just a 2-minute balloon inflation. So it's a good balloon. We have had good experiences, but hopefully this will work well in this lesion as well.
So what we're doing now is Vishal is up to 4 atmospheres for a few minutes, right, Vishal?
Yeah,
I mean,
just a minute.
And then now you're going to go up again, or you leave it at 4?
No, we lift to 4. We go up to 6 for another minute.
At 30. So we actually have a timer for those of you at home. We probably have one of the largest experience of Serenator in the world, and I can tell you that we've had very good results with this balloon. And full disclosure, none of us have stock in the company, and
nobody wants to give us stock.
and so I think that we really believe in the technology. We love Peter Schneider and his mind, and so I think that this is a great balloon, and we really love it. So we're up with this balloon, and we really believe that this is kind of the new way to do angioplasty in these kind of lesions to avoid dissection. Right. One of the limits of this balloon is the sizing. They go up to 5 in the SFA. I know they're working on a 6 and probably even larger. And I think it's gonna really work out well. Yeah. So we leave this balloon up for a little bit, and our idea is just to cut the ostium and the distal pop. So down. Right. So what I may do.
So I guess the question really, Raman and Karthik, is like, how do you deal with this sizing mismatch? You know how you can see the tibials were 3.0.
So we're just going to go up here a little bit.
The distal pop was 4.0.
You still want to go up here, PK, because the TP trunk segment looked pretty good, right?
Yeah, but you know what happened, Karthik? There's a little distal lesion that we want to get. You see when the balloon went up.
You see the waist. I saw the waist at 21. Yeah.
So that's why Vishal was telling me to go up a little bit here. So we pulled up together. Look, part of the problem here, Karthik, is the IVUS and Raman, the IVUS always shows horrible disease. What's physiologic, what's not, right? So that's why I was thinking about a pressure wire pullback, or we can do a cheap man catheter pullback, and see what it is. So the popliteal, like I said, looked very diffuse. The SFA, we know in the areas that we pointed out are extremely tight. So one thought is forget about the physiology in the sense that take care of the tightest lesions that you know on IVUS as well as on angiography. Use a combined therapy of doing both, and then balloon those lesions. The other thought is, hey, you know what? The whole vessel is diffuse. Let's go ahead balloon the whole vessel and do a full metal jacket. So Vishal and I have been struggling with this one since this case was brought up to us by David, and so what I think Vishal and I have decided is right now to go ahead and just treat the areas that we feel are very tight. So which is the numbers we gave you. We got that moderate segment in the SFA, the proximal segment in the SFA, and this distal segment in the TPT and PT. So down. So when we walk this back, I'm going to run the IVUS through. David's going to get my IVUS ready for me, and we're just going to walk this through. So we're not going to even take a picture. Let's run the IVUS, see what the lumen looks like. I'm just going to run it on the areas we ballooned, and Vishal as he walks it out.
PK and Vishal, like, I know it's diffuse segment disease, right? And the vessel looks like 5-0 to the most. If I have to really push it, 6-0. But if you do a long, if you do a long segment DCB and you IVUS it, you're going to see dissections. There is no doubt about it. Yeah. But as long as there is no recoil in the vessel and you have an expansion of the vessel, I think it's okay to leave it with DCB, right? My understanding is the main failure based on the impact data is the failure of DCB is recoil of the vessel, right?
Right,
PK?
right. Yeah, exactly. Yeah. But that's the thing. That's the thing, Karthik. What if when you and how do you assess it in this patient who has no, you don't want to give any dye to, you don't want to run this dye down too much. I mean, what do? Do you just do IVUS and leave the dissections?
Yeah, I think so. Yeah. IVUS and leave the. IVUS always makes it look worse, as you said. Disease or dissections, it always, as long as the vessel is expanded and we have got the luminal gain, I personally feel like it's okay to leave the dissections with DCB.
So we didn't balloon this part. We started ballooning right here. There you go. You can see some of the calcium. But, the luminal gain is not a lot, but at least we have gotten rid of the.
I think it's almost 2.5.
That's the tightest spot.
Yeah, that was the tightest spot.
That's the tightest spot we had on the initial IVUS. And the distal, now we've definitely opened up the distal. Yeah. So then there's the area with some atherectomy. We can do more atherectomy if you guys want and try to get it open even bigger.
I would not.
Probably,
I would probably leave it. I think you got the, it's 2.530 luminal gain. I think that's what we are looking for.
So listen, I want to do a live IVUS for you guys of the pop. I pulled it out, but I'm going to go back in now. I want to do a live IVUS for you of the pop here. Hold on.
The other question
is back live, guys.
This may be one of those good cases because as far as remaining steps, I think we're already past the halfway mark and we still have quite a bit of time. It would be nice to say we've done one level of therapy to the PT distal pop lesion, and let's IVUS now in like 15 minutes and see if there really is recall. Make a decision based off of that.
Okay, so I'm going to pull the IVUS.
What we really have.
This is distal pop.
This is distal pop. Yeah, I'm on live. Guys, put my live. Take me off the screen. Put live fluoro and live IVUS for them, please.
Yeah.
Take us off the screen. Put live fluoro and live IVUS on the screen up there.
The live transmission. Yeah.
Yeah. Thank you. That's great. So you can see where the IVUS is. Wow, you guys love me. You don't want to take me off the screen. So anyway, so here we go. As we come up, you can see here. See the pop here is okay, guys.
Yeah,
see, it's over here. It's okay. Like See, all this we can generally leave it, right? But watch when Vishal says. Let's see. Look at that.
Yeah,
the right at the mid pop.
P1 segment. Yeah.
See that? Look at that. So right around the end of the glow tape. So that's really tight. That needs to be treated, right? And then this area he needs to be treated. And then now we're getting to be okay. It's not perfect. It's not going to be perfect. Right now look at this right here. On the E of glow tape, you have eccentric plaque. So basically, you need to treat the entire glow tape segment. And then as you come up, you can see here even this area.
Still there.
Except now you're better here around the distal SFA. I would probably leave it. It's not very, but look at the amount of plaque. It's unbelievable. Do you just DA the whole thing? And now look, I would probably leave that. Yeah. See, I wouldn't touch that area.
But wait till 10.
And then watch at 10. Look at that. Right there. So right at 11, severe plaque. So Raman may be right. Maybe, now look, now you're again fine. And now look.
Look at the calcium right there.
Now look at the calcium as we get forward into the segment.
Right there.
Look at that. See that? So now
So I don't know if you can really do spot ballooning, leave those segments. You'll end up overlapping so much that essentially the entire segment gets ballooned.
Yeah, that segment too, out of 15 was very tight.
So we talk about 15 to 17, 19 to 21, 20, like pretty much like 2
So I'm going to show up top here where we mean, look at that segment here, we're down here, look at that. And I'm going to show you up top where we talked about by 30, where we knew was really tight.
Very calcific.
And so this is where Vishal was struggling. Look at that. Look at that. Yeah. We just passed it.
You probably never hear me say this again, but given the diffuse, small, short
Shockwave guys,
segmental lesions all the way through, if a long DCB, I think is a very reasonable approach.
Exactly.
But
a 5.0
I will probably
DCB,
never say
5.0
this again,
250.
but this may be a good case for tack stenting.
Yeah, I was just thinking, but the only problem is tack stenting doesn't have the enough radial strength to keep it with so much calcification. There will be so much amount of recoil.
If we're going to shockwave, DCB,
we can. Yeah, absolutely. It's not a bad idea actually at all. You can locate your lesions with IVUS, put it on roadmap, and just keep deploying your tack stents wherever the IVUS is.
So I'm just going to go forward. We decided to shockwave because we knew there was eccentric and concentric calcium, but more concentric in the mid segment. So Vishal and I just,
given the fact that you have your EXL, we see that the vessel is about 6 and change. Oh yeah, that's not going to touch. Never mind. Scrap that idea.
Yeah, so that's why we left that idea. So we're just going to hit the calcified segments like we talked about from 11 or 12 on. So from this segment on, we're going to pull back to shockwave. So Vishal is going to go ahead and shock here. We're going to watch the expansion. And then I think now, looking at that IVUS again with all 8 of our eyes. What's that, brother?
This is a 6.0 shockwave, or
no, it wasn't calcified, right? Yeah. I mean, we could do that too. You want to do that? But I think
this is a 6.0 shockwave or a 5.0 shockwave?
We undersized the shockwave car. I think we went with a 5.0.
I think the vessel is 5.0, so I think it's
right,
totally okay.
These are 2 millimeters, right? So each dot 2 millimeters. So this is a 6. 1, 2.
Oh yeah.
It's almost 6.5.
No, it's not a 6.5. That's for sure. I think it's a 5, Roman. We asked for a 5.
I mean, you can use this in the POP too if you already have it. So at least it helps you with the DCB. So
I agree. We may go down and use it in the POP, and then like you said, DCB the whole segment with a 5.0.
PK, as you said, and now you can put a filter down because you have a pretty good luminal gain in the PT. You could always put a filter down and DA the whole thing.
Well, so those are the options, right? But yeah, I think this is well expanded. We don't need to go anymore.
Just let me.
We'll just let save shots, right?
Yeah.
So I mean, hopefully, I just want to crack these lesions. You apply the drug and then come back. So I'm going to go forward. I'm going to come back. Michelle wants to come back a little here, which makes sense. We'll do the whole segment here.
See the calcification.
Yeah, the calcification. Right. Hold on.
We are on the lowest fluoro, so you don't appreciate it. But looking at the screen, there is almost like a tram track calcification right there. Okay. You're going to see how it expands the balloon.
Oh, mm-hmm. So this is very tight.
And for that glow tape lesion in the P1 and 2 segment of the POP, that's gonna be just DCB. Is that correct?
Yeah, that was the plan. I mean, we're talking
about now we're probably going to shockwave everything. We're probably going to shockwave even the POP. Yeah, and then we're going to go up, and then we're going to do another IVUS, and then we're going to do DCB, and then maybe spot stent, like you said, with either a silver. Sure. Yeah, we'll do one more here, a silver or a Sapera. So one of the things, so there was a lot of talk in the conference, guys, about Alluvia. A lot of people are using Alluvia. We seem to be a big silver fans in our lab. I mean, what are your thoughts? I mean, it seems like everybody seems to be leaning towards Alluvia now over silver. But I mean, we've had great results with silver PTX. So I don't know. I don't know what your thoughts are on that.
I would take one more shockwave the cycle there, Vishal.
Yeah,
we did too. Yep,
I did too.
Good, right there. Go up there.
Hitting one little overlap of that segment approximately. Yeah. You still overlapping.
I still see that. I still see the waist.
So see how the mid segment
the thing with
up?
Alluvia is that they had the 018 system for a very, very long time, and silver only recently kind of,
Right.
I think the other issue is that these, the long-term data was out with silver first.
Yeah, I mean, I have used both stents. I don't know if there is a major difference. I mean, again, you need to have a large patient population to say that. But just based on my experience, I don't think I have seen any major difference between both the stents.
Yeah.
Perfect.
Well, the data was supported after 2 years. Yeah, I mean, after a year. Down. So
we have used silver for a long time, PTX, and I don't really see much of restenosis anyway. So
go up there. There we go. So we're going to do 2 more shocks here and then go down to the POP. There's another area right there. There you go. Expanded nicely.
Yeah, it's like having those napkin rings going up.
Yeah, so let's see. And then let's see how it looks. So one of the nice things.
The only question is with the amount of plaque you have in the P1, P2 segment, PK, I don't know how just ballooning will take care, PTA will take care of it. I think you might have to atherectomize that, at least that segment. That looks like the segment with the most amount of plaque.
I agree.
Yeah. I think probably doing a focal atherectomy of that area is not a bad idea, just to avoid stenting that zone.
I agree, buddy. I agree. So maybe we'll go with get us a Silverhawk M. We'll make one pass in the pop.
But you're right, Karthik. I mean, this is one of those cases where we might end up using 2 atherectomy devices. I mean, everybody wants to work with one and try to do it, but in order to do a true justice to the lesion, we just
okay, then let's go down.
Yeah, I think so. The amount of plaque
I agree with you 100%. I think this, like I said,
for the pop segment, you could probably get away with using the EXL.
EXL, that's what I was about to say.
Oh, really?
Yeah, I think so.
I was thinking EXL. Yeah, it's a 4.0 vessel.
No, it's a 5.0 vessel, guys. There's no way EXL is going to make a difference there.
I know, but you just need some plaque modification, right? Because that's all you need. So I'm saying, like, instead of opening another device with Shockwave, the expense, I mean, I know we don't look at the expense in live cases, but
I agree. Let's go with the EXL. We'll take a look.
Yeah.
Then don't
you
open
can do
the
like
other
4. You can do 4 cuts instead of 2. You can do 4 cuts. So I think it's totally okay.
Go up. See, look at that lesion right there. So we're gonna go there. Just cracked. So Vishal went up, to 4, and like they tell you to do. And then I think it definitely cracks. So one of the things I do in my practice is I go to 2. And then slowly start shocking a little bit, and then go to 4, and then this way I think it really prevents dissection. So now that it's expanded, I'm not going to cut it there, guys. It's already expanded, so I'm not going to cut it.
Yeah, let's IVUS and then
do one more.
Yeah.
Well, get ready for an IVUS. So we're going to do 2 shocks here, and then so now we pretty much have expanded the whole thing. And let's see, maybe we should do that internal, the segment in the middle there. We won't have enough shocks. So we're pretty much done with this balloon. So we've used all the shocks of this balloon to expand this lesion in the SFA down. So I'm going to just
bang for the buck.
Yeah. For clarity, what is his creatinine now?
It's 1.8, right?
1.4 now.
1.4. The problem is it rose from 1.1 to 1.4.
Yeah. Oh boy, that's very cautious.
Wow.
I would have taken a couple of pictures.
Come on.
A couple.
Let it be sure. Let me see where it is.
I think your concern, PK, is he's very high. I mean, he has very high propensity to have CIN, right? That's why you are concerned about it.
No, the wire's out. Wire's already out.
Yeah, I think that's why you're concerned.
Yeah, the wire got stuck in the Shockwave. Give me the wire back, guys.
Yeah.
We'll rewire it.
What's interesting?
You got stuck in the Shockwave.
Okay.
New wire, guys. That one probably stretched out a little bit.
That's a steel core. That was a steel core wire you had.
No, it was our command.
New
Let's just do
a run through.
No, just this injection with CO2.
Yeah. Hold on.
Give us a run through then. Vishal wants a run through. I've never used a run through in the peripheral, so let's not use it now. Give me a command.
You can use your Spartacore now, so I think it's totally okay. Yeah.
Ready?
Yeah.
It might help you with taking a long DCB in.
One second.
With the strength.
Perfect. Good.
So very nice result.
Look at the little gain.
Yeah.
Very nice result already. So let's go ahead with the command now. All right, and then we're going to run a quick IVUS through, and then we're going to start.
Nice.
Everything okay, Chip?
PK, you want to do a long DCB and then run an IVUS, or?
Yeah.
Okay, let's do that then.
Probably
if you want.
because it gives us an idea, right? Then you can decide on stenting or not stenting. So.
Makes sense. All right, let's give us a 50 250 DCB.
250 DCB. Yeah.
Ready.
Might need 2, but yeah.
Show me down. Above me. So we're just going to go carefully since we've already ballooned this segment.
If you form a loop, I think it should just go through. You can take that loop probably.
I always feel uncomfortable when I don't know if there are dissections or not with a loop. This is the area that was really difficult. I think here I'm okay.
Yeah, now it takes a turn right there.
Oh, okay, good, very good. All right, let's get the.
What's your leg? Okay. That's good.
Okay, we're going to 5.0 long DCB. So we're going to do this on a.
Yeah,
so I think we're going to do this on an 014.
Yeah,
and
it
you
should
know how
be
this
fine.
thing
I
gets.
think it should be okay. Yeah, I think you have caused enough luminal gain. I think we have reached it. I think the expansion was great. It should go in very easily.
Yeah.
If you have, like, after this is what we decide, right? If you have multiple areas of dissection, PK, Vishal, Raman, what would you do?
It kind of just depends on how far they are and where they are. I think more distally, probably go with, hopefully one Sapera. Leave the less significant ones.
The G, right?
Okay.
I did mention tax stenting, but that was it made me feel as if that was going to be more and more focal ones. But just looking at that runoff, I feel as if maybe we'll be more surprised by our outcome than what we had originally expected. So I would probably just take one Sapera, maybe two, depending on how far they are.
Nominal
two short ones, one long one, depending on where they are. I think that would be.
So, guys, reset the timer for us, please.
And then if we still have to deal with the proximal, if this 250 doesn't take us all the way up, if we still see some disease proximally, that just to a spot, DES could also be done.
Okay. PK, Vishal, what would you guys do?
That's a great plan. Honestly, I think it's a great plan. But Vishal and I really want to try to avoid anything more than spot stenting.
Yeah.
Because I think we both feel that long segment stenting in this gentleman with such disease is not going to do well. Okay. So, yep. So you're at, go a little higher, go to 8 or something. Yep. So we're at 8 atmospheres here. That's perfect. And I'm going to leave it up for 3 minutes. So the other issue here is we're probably going to need another 200, right? Or maybe not a 250.
Yeah, probably. 150 should be enough, I think.
I'm just wondering, we haven't really looked at the ostium of the SFA.
Ostium is even higher than the glow tape.
Yeah, that's what I'm saying. Maybe go with another 250, get a little overlap.
If there's an overlap, that's fine.
Yep. Get us 250 impact, another 50.
Yeah, I think in this case, we'll do an IVUS. We'll see dissection planes like Karthik talked about. I mean, I would not be hesitant taking a hand injection, 3 cc diluted, and we have a 48 mag. We could technically see the whole SFA on a 3 cc dye, but to at least finalize if you really need a stent.
Very low mag, you won't see the dissection, so it'd be good.
Well, it's better than doing a.
I mean, I don't know, PK. I mean,
if there's flow limiting or not, you'll see.
I think DCBs came out when I graduated. I think 9 years I've been using DCBs. What I have observed is this long segment DCBs. Even if you see dissections on IVUS, which I see all the time, I think if they're not flow limiting, especially with CO2, if they're not flow limiting, you can just leave them alone. They have restenosis, but I don't think they have any significant restenosis. As long as there is no recoil in the vessel, I don't think stenting has any role in this. I think they remodel themselves very nicely, and I think it should be fine. At least I have observed that patients do very well for at least a couple of years.
No, there's no question. And the data supports what you're saying. There's no question. I think that, if you look at the impact long data, I mean, the only thing is it's 40% stent rate.
Right.
Generally, most of them were for really, truly flow limiting dissections. And so, obviously our data with impact is a little skewed because we don't know what the impact that the stents had on these lesions. We do know with complex lesions, we need to stent a little bit more. And I think Vishal and I are agreeing to stent. We just don't want to stent the whole SFA. So now that was 3 minutes, and now Vishal is going to come back slowly, let the balloon deflate. Because, this thing is literally a semi, it's a truck. And as much as we tell Medtronic, please give us an 0.8, they're trying their best. I'm sure they're going to get it out at some point. But they came out with the longer 0.18s, but not as long as 250.
Yeah, 150 is the max.
Yeah. So as much as we're begging them, it's unfortunately they haven't quite gotten there yet. They will, and when they do, we'll be the first ones to use them. So right now, as you'll see, the Ray's fixing the sheath for everybody at home. This balloon is quite difficult to get out, and Vishal is trying not to bend the wire with all his strength. So anyway, now we're out. You don't need to go further. He's in the sheath, so he should be fine. So let's come back down. So now what I want to do is make sure we see where the ostium is, because I know there was some osteal disease that David spoke about and David showed us. So I just want to look at the ostium of the SFA and then decide here.
Give me the.
So Vishal, if you're okay.
Yeah.
Well, make sure there's no air, because when I went in, I heard some suction.
Okay, let me.
So just make sure there's no air, guys. Yeah. Watch it, Ray. I'm sorry. You're good?
Well, okay.
As long as there's no air. Good. Okay, no air, right?
No.
Okay. Wonderful. Okay. So we're going to do a quick DSA here. And I want to see where the ostium is, because we know we got plenty of balloon length, right? So So yeah, the ostium's okay. I'm going to leave the ostium, guys. What do you think?
Yeah,
right?
that's why I was saying.
I don't want to mess the ostium.
Yeah, that's why I was saying 150 because even on IVUS, I think your proximal segment above 30, everything was fine.
It's just that one.
Just that one segment at 30, or just
So
before 30. Yeah.
Show me where the balloon ended.
200.
Show me
about
20. Okay.
Yeah, 20.
All right,
Exactly.
then we're good. Then we're good. So let's.
250, do a little bit of lower lap, and you think you should be.
Wait,
150 should be good.
150 should be good.
Yeah, I think so.
Where's pressure, guys? Yep, 150 is good. Give us a 150. Okay, good. We're gonna go with the 150 here. And if we need more, we're gonna ask Raman to give up dinner.
It's part
tonight.
of the paycheck.
Yeah. So that's all. No dinner for tonight. So you know, for those of you at home, Raman consumes the most broccoli in America. So if there's a shortage, I want you to come to New York and ask Dr. Sharma why he's eating so much broccoli. So go to his house. There'll be 3 refrigerators full of broccoli. We know. All jokes aside, we tease Dr. Sharma all the time.
I actually had broccoli in my salad last night. So.
See, there you go. That's what I'm saying.
I don't know. At least I would say out of Mount Sinai Peripheral team, one of us is healthy. So I would say
exactly.
I think we should. I think Raman's pride we can all share. I think so.
That is true. That is true.
I'll tell you, with the HDL of 114, things are good.
There you go. 250. All right, there we go. All right, so that's pretty good. We'll just go a little bit past 20 to prevent geographic miss. And again, I mean, listen, we're not looking for perfection in terms of how the vessel looks. We just like to get the lumen open here. And then this is the 018 by Medtronic. It's, again, much easier balloon for us to go in. So you can see look how tight that lesion is proximally. Yeah. Look at that thing.
That was a real
So
spot.
that was the area that we expanded with the Shockwave. And now we're going to have to expand this. And that's the area we may have to put a stent. So there you go. So Vishal's going to go up to 10 and just really get this, open and prevent it from recoiling. So now we're going to, again, watch paint dry here for 3 minutes. And so let's talk a little bit now about surveillance, guys. I mean, obviously, you know, we're trying to do as much balloon expansion as possible and try to get this guy's symptoms to relieve. And definitely, I think his rest pain will go away. But the idea would be is how are we going to survey him? What's the antiplatelet strategy? What's the statin strategy? Like, for instance, European guidelines for statins say that the statin LDL should be 55. U.S. guidelines say 70. And maybe are we behind? Is that too aggressive? And how do you guys manage these patients in terms of first statin, second also antiplatelet agents?
Yeah, I mean, I think first things first in regards to this guy's LDL. So from the 4 years data, we know that you have even less revasc when your LDL is below 55. So putting this person on a PCSK9 inhibitor to me is a no-brainer, given the amount of as David had said, this guy is a polyvascular path. I think getting this guy's LDL, even if it's in the teens, I'll be fine. So I would add Lipitor 80, PCSK9, add Zetia, whatever it is. LDL of 6 to me is perfect.
I agree. No, I'm not. I've actually been very aggressive with my carotid stenosis patients. We're putting them on PCSK9 inhibitors, and we've been doing a really good job, Ray and me. But I agree with that. But what about now? So if this gentleman, I believe he's on Crestor, right?
Yeah.
So,
What is he, David?
he's on Lipitor 40.
So he's on Lipitor 40. So would you first up that to 80, and then check the cholesterol, and then decide? Because we have his labs. Jen, could you look up his labs and what's his LDL?
It's like 50.
It's 50. Okay, so it's 50. David's well prepared, thank goodness, as always.
Yeah, I would
50.
not change anything if it's 50. It's totally okay. I think 40 is fine. I think if you add PCSK inhibitors, I think it's totally okay. I think it's fine. It's 40. It's just there's a big difference between 40 and 80. It gives a lot of myalgias. So I think there is no reason to make him go towards that route.
I mean, this is an interesting question, right? Because you have a guy whose LDL is low, right? And it's even by 4 years, it's where it should be, right? But he's still he has a terrible vascular path, and largely it's not even a very calcific problem. This is mostly atherosclerotic problem, right? So even despite being on maximal, statin therapy, and even with the LDL in a relatively appropriate range, the other question is, with all these new drugs down in the pipeline about the Lp(a) reducing agents and all that stuff, where is that going to fall into a case like this?
I mean, I don't think he'll meet the criteria for the newest injectable drugs because he's tolerating statins very well.
And he's not
So
on max dose.
he's not on max dose, and also he's tolerating statins. If they tolerate statins, everything is.
Well, remember, so far as the PCSK9s, it all comes down to what the LDL is, right? And if you failed your two therapies, but if you are on maximal therapy or even not maximal therapy, and your LDL is less than 55, right? You'll have a very challenging time getting this drug approved.
Yes, absolutely. 100%.
That being said, I would still try, even in this guy.
Yeah.
Yeah, I think. What about the question of using your low dose Xarelto in this case, where they're
No, that's a.
Eliquis.
He's an Eliquis already, right?
You can't do that.
All right, distal pop.
Sorry about that, yeah.
Again, put the IVUS up, and you can make us small or disappear us, whatever it is. Okay.
No, the
IVUS.
IVUS. Yeah,
Thank you.
Perfect.
Distal pop, guys. Ready? You can see something floating in the wind.
Yeah.
On. IVUS on. Record.
Yes, it's on.
Thank you.
I think there's good. I mean, again, good luminal gain more than. I'll show you where we are into reference. Remember we talked about P1, P2 segments, so that was all good.
It's actually a very good luminal gain.
Yeah.
Yeah.
Just
Again,
keeping
it's
the floor
good,
on
not-
just for
not
you guys
great,
for marker.
which is good.
And right there. And I'm gonna
No
see-
real dissection so far, guys.
That's still tight.
Right there, right there,
Yeah.
right there.
I think that segment still.
So maybe we have to put a Sapera here.
I would definitely put a Sapera there. Yeah. There's a lot of
15.
recoil.
Yeah.
All right, get
oh,
us a 6.0, actually a 7.0. What is it called? 100. This balloon. You know which balloon, Damien? The high pressure balloon. I was
The Dorado.
Dorado.
7 or
Nope, this looks really good right there,
Yeah.
Karthik. Look at that. I'm very happy there.
Yeah.
That's fine. Yep, we got the procs, so we're not worried about the
Yeah,
procs.
I think that's just calcified segment you have to stent. I think
Yep.
that should be fine
Like
if you
15 to 20 or something.
Yeah.
Or no, even further back.
You want a 7 or Dorado? Yeah, 7 or Dorado, please. Yeah.
7.0 100 Dorado, Damien. So yeah, I've gotten really
Yes,
aggressive
7.0.
using the 7.0s because I think the maximum luminal gain with the 6 is going to help us here. 7.0 Dorado, we're going to go through with it.
Yeah.
So 7.0 100 across that. So he's going
here's-
to have a
here's
little pain,
another
Jen.
thought. So we just measured the vessel again, and it's like 6. I mean, we went with the 5. Would you, in hopes to, somebody who you're really trying to avoid putting long stents, this is a 6.5 almost. Would you want to do a prolonged balloon inflation to see if you can tack up some of these, do a little bit more PTA before jumping to the planned oversized balloon and dedicated Sapera?
That's what I was trying to get to is once they have recoil.
Correct.
I think PTA has no role anymore. That's the biggest
Exactly.
failure for DCB.
Yeah.
But this isn't recoil.
Oh, this is severe recoil,
yeah,
especially
recoil,
in that 20 to 10 to 20 segment. That's severe.
It's
I
recoil.
consider
Look at
that severe recoil. When
Take
I
it
was,
out. Give
if
me a
I see
super
less
core.
than say 50% reduction in the lumen when compared to before, that's a severe recoil to me.
No, this is so bad the Dorado. Well,
That's-
Dorado
I mean,
doesn't go
as per
through
the
much.
as per
But,
the impact study, that's what they look the definition as severe
no,
recoil.
but,
So-
but
I
then
think
don't
this
open,
is
Dave. We
just
got it.
inadequate plaque modification. That's it. Because the
That
plaque
could be.
is
Or it
what's
could
the
be a
issue here.
combination of both.
Combination. Let's be careful there.
Yeah.
This could be a combination of both. I'm not denying it,
yeah,
but Raman, I agree.
absolutely.
Get us a new one, guys. A new Supercore.
Because we used a Shockwave and we
Not-
used a
I don't
DCB.
You don't like
So
it?
I don't know
Okay,
what
stuck.
New
else.
Supercore?
I mean, you can use a 6.0.
This is
You can.
kinked at the top. See, it's right there.
Where is the sheet tip? Oh, sheet tip is there. Okay.
Okay. Now
Should
it's
I
going
go with the
to.
lead with the Supercore then?
No, it's just. I won't take my turn. I just have to probably pull my sheet back a little bit.
Oh, so the sheet is kicked now?
Yeah. Hold on.
No?
No, I think Dorado is just a bulky balloon, so sometimes
Yeah.
it might.
The
It's just the
Ultraverse.
taking-
I think the bifurcation is
No?
very sharp,
Yeah.
so it's probably just not taking that bend.
Yeah, it's just the Dorado that was.
Yeah,
Okay,
it
now
probably
it's
went
done.
through, right? Yeah.
Yeah,
Yeah.
it did. Show
Yeah.
me done?
I think it's just pulling the sheet back and then I think it's just it prolapsed into the profunda there.
Yeah, no.
Let go now. Let me see if the wire. Okay, go with the regular wire.
Yeah. Wow. You can feel the kink on the top.
Yeah, give me a regular wire. Let me just wire it.
Yeah, I think we should do that.
Let me wire it with the 035. Is that a new one?
Well, no,
Yeah,
this
we
is
can
old
take a
Wooly.
No.
Need a new Spartacore.
Spartacore,
Supercore.
Supercore.
Yeah.
Okay, new Supercores here.
Mm-hmm. Thank you, guys. Guys, flush the sheet for me.
Mhm.
Did you give more heparin or no?
PK, you want to put a Sapera there, or you want to put
I don't
any
know.
other stent there?
We might be able to put his. To me, if you're worried about calcium, I think you got to go with Sapera here.
Yeah.
I think it's more about recoil.
I don't know
calcium,
if
I
it's.
guess.
I don't know if it's the. I think Zilver should be fine if you want to put a DCB.
Okay, good.
I agree.
All right, we already DCB'd, so let's go with
drug?
Doesn't really
not. I don't think it matters at this point of time. I think we have enough data to show that it doesn't really matter.
Yeah, if you want to be cost effective, then yeah, right. You don't
well,
want to, but
let's first dilate and decide. Then we have the IVUS as well. We'll decide here. Okay, so I'm going to go here. Now it's going really smooth. No problem. Yep, we're fine. It's going to be fun to take this thing out.
I think you have an 035 wire. I think it should be okay.
Okay, we're going to actually it's further back. All right.
Yeah, that's what I was thinking.
Yep. Okay.
Go forward. Good. You happy?
Yep. Go up here. Okay. So we're going to really crack this, guys. What's nominal? What's
8.
nominal? Okay, breathe.
I'm still at 4, 5.
5, 6, 7. Breathe. Talk to him, Ray. Breathe. 9, 10. 10.
Yeah.
Okay, that's at 10 atmospheres.
Huh?
Breathe it out. Okay.
Yeah, I did.
Go to 12.
I am.
12 atmospheres.
And then you want to change
14.
this wire to an 014 now, PK?
14.
But it depends. If you want to do silver, I'll keep the same one.
Okay, down.
If you want to do
So, guys, one of the things at home I want to talk to you guys about is vessel prep. Like, you're either going to poop or you're going to get off the pot, right? I say that often. It's the truth here. Go up, because this is a stent that we know performs very well with vessel prep. So you have to, right? So here's vessel prep. That's at 14 atmospheres, down, and then down. All right, now the problem is when we're gonna really struggle, because we're gonna have to go with an 014 wire as the way.
Are we doing Sapera or silver?
Well, I think we should do Sapera, no?
Okay. No, I want to know. Then we exchange the
Actually,
wire.
you know what? Let's walk this out and do a wire exchange. Walk this out, because it's not worth it. As Vishal and I know, we're going to struggle with the 7.0 coming on through the 6-French sheath. So we're going to keep this wire down. Get us a straight catheter here. We're going to put a straight catheter down. See how difficult it is, guys? So I'm actually walking here as Vishal is pulling. And so this way now it's out. If we had an 014, we'd be struggling like crazy to get it over that arch. So now I'm going to take the extra step here to go and change out for my Spartacore the way Karthik suggested and Raman suggested. So we're going to go now, and then we're going to do a quick IVUS with the Spartacore. So get us a Spartacore, guys. We got 5 minutes to deploy this. Get us.
Question. So a lot of people would have a little bit of a tough time. You feel uncomfortable to go to 14 and with a 7.0 balloon like this.
Agreed.
That being said, experience-wise, you are actually quite safe. But what if this was a CTO and you had you cross some degree subintimally? Would you still be this aggressive if you're going to be doing a Sapera afterwards?
Well, I really think that you're right. You have to be careful if we're subintimal. If I'm putting a Sapera in a subintimal plane, I have severe calcium. I think you have to, because I think you have to be prepared to know that the larger Sapera is going to stay open more than the smaller Saperas. So as we know, Raman, in our experience, and we haven't published our data yet, we have a lot of Saperas. 5.0s and 4.5s do not work as has been said. Yeah. But the problem with us is the 6.0, 6.5 seems to work very, very well. So therefore, I think that in this situation, it's probably worthwhile to take the risk, and then if we need to, put a Vibon in. And that's part of the reason why in these very complex lesions, Vishal and I chose to go with a 7 French sheath. So let's go ahead and take a picture here, guys. So we're going to take a quick IVUS now. Let's do an IVUS. So we're going to come in with the IVUS. We got 5 minutes left. And then we're going to show the Sapera deployment, take one shot, and then we'll finish up here. So
would you want to take one picture of a CO2 just to make sure there's no pee or anything?
Yeah, okay, we can do that. Michelle, let's take one picture.
Doesn't look like he's in that much pain.
He's not reacting, so I don't think it's necessary. Yeah, let's go forward. Yeah. So we're just going to go with the IVUS, and hopefully, Raman, with that, we're right and you're wrong, because you said you said you said we should have prepped the vessel. So with a more so we'll start here. So record, guys. So we're recording, and now I'm coming back here. As I pull back, I'm going to go on fluoro. You can see here I'm coming up to the area where we started ballooning.
10, right.
Here's 10. Look at, and now we got, oh, look at that. Very nice.
Oh, no.
Very nice. We definitely expanded the vessel very well. Again, there's a little recoil there, but we know we cracked it with this balloon. And so now we know we have to send. Look at that level of recoil, Karthik.
Yeah.
It is unbelievable.
Unbelievable, right? Yeah. It's crazy.
Oh
the amount
my
of
God.
recoil
Look
is
at that.
crazy.
All right.
Look at that recoil.
So
And the
120,
dissection, you can see.
120 Sapera?
Even
We're gonna
longer,
go there
PK.
I take 150.
You
straight
might
up.
have to go
150?
until.
We didn't prep 150, did we?
No, we
We-
didn't.
We didn't prep. Let's go 120.
120.
120, 120, guys.
PK, you have
Go
to
with
go
this.
from 10 to 25.
No.
No, from like
Yeah, no.
16 or
That's what I was
17 up.
thinking.
10 to 25. So because you ballooned it
But then we
until
have to
25.
reprep.
I see
Yeah.
the
We have to-
dissect. No, I think you.
No, we didn't balloon up to 25. I know that. Give me a 7015 Viatrack, guys.
Yeah.
So we're gonna balloon that with a
See the amount of
7015
dissection we
Viatrack.
have all the way from 3 to 9 o'clock.
So remember the what Karthik and Raman was saying. Without vessel prep,
Viatrack first.
this stent is
Viatrack
gonna
first.
fail. So
Vishal,
Viatrack
you want to
first,
go on
please?
the previous picture, the balloon saving image?
Here, this is the last one. So at 21 we stop.
So we had to go to 25.
Okay,
7015.
25.
So yeah, so if you want me to send till 25, we got to prep till 25. So we're gonna go with a 70 Viatrack, which is a renal balloon from Abbott, and we're gonna go ahead and stent this. And I think, balloon this and prep this area here. The reason I didn't go back with the Dorado is I don't have an 035 wire down.
Yeah, I agree. I think
Yeah.
that.
And this is a nice balloon, as you know, Karthik. It's and Raman, it's a nice monorail balloon.
I'm
You got it?
so surprised with 7.0. There is so much recoil.
It's tremendous, right?
Yeah, with Dorado, that too.
That's pretty wild.
That's crazy.
So now we're gonna go in. So we're gonna go up to this level here. I'll start at 20 to show. It's okay, I can see it. So we're gonna start at 20 and re-prep that area to 25. So there's 20.
Now, granted, they were a little bit further out in the treatment stage
Nominal
here.
rate.
Would you have considered doing some other form of atherectomy now?
14. Down.
I would have. I think DA would have been DA or CSI would have been totally fine here. Long segment. The only problem
Down.
is embolization is for him.
Yeah. Now here's the other thing. This is only because of what we're seeing on IVUS that we're second guessing, triple guessing ourselves, right?
True.
Like, what are the chances that we take a?
I think we are good, PK.
Like,
Right
let's
there.
say like
One more right there, that's
the
it.
angiogram was totally
it's
fine.
Down.
Yeah.
Okay, good.
Okay.
So what are the chances
So-
we would have actually done all these extra steps?
But can I tell you though, isn't that better that IVUS is making us better interventionalists? Like we know now that
I
of
agree
course
with you,
we would have been like, I know we have no outcomes data. I'm not saying we do, but if we, and unfortunately,
60150.
what we have Eric's data that talks about 60150. Eric's data that talks about
120 or
150.
150.
150. Sorry guys, 60150. And what we're going to do is Eric's data obviously shows better outcomes in patients who had IVUS versus not. But again, that's from a large Medicare population with not a lot of granularity. But we need to have data with IVUS. But I think in this case, you and I would have probably stopped after this, our 5.0 DCB.
Without an IVUS? Yeah, definitely.
Without an IVUS. And
Definitely,
we've now
yeah.
ballooned with a 7.
Yep.
And we're putting a 6.0 Sapera, which completely changed our algorithm.
Yeah.
So hopefully this will help them more. But that's the question. We want to get the best outcome for this gentleman.
Correct.
So we'll take a look here.
I think
This patient,
sizing.
if you didn't do IVUS PK, this patient would have definitely come back in 6 months with severe restenosis.
And
So I think you're right.
I hope.
No
yeah,
doubt
I
about
agree.
it.
Yeah, the sizing, we always tend to undersize with IVUS, and we know that right from DCB data, the undersizing was the biggest cause of having restenosis in DCB. So I think that's
No, but in that IVUS study, the IVUS arm actually got smaller
correct.
DCBs.
Yes.
That,
And the differential,
True.
right?
Which is kind of odd. If we're saying that the
Why?
issue that you inappropriately
I don't
No,
think
but
it's
70
undersizing because even if you took a 7.0 DCB, the recoil would have been the same.
I don't know, but I'm just saying
So-
the data suggests there was a 79% change in game plan, whether increase or decrease size, if you did IVUS versus somebody who did not do IVUS. So if you want to appropriately do it,
So we call Vishal, Raman, and Karthik the Supera whisperers. So Ray always tells me, let's call him in PK, please. So so I listen to Ray for most
start at
everything. So we're it's very difficult, obviously, all jokes aside. So
This
he's
is a
gonna
6.0
demonstrate.
Supera, I'm assuming, PK?
Yes,
Yeah.
it is, Karthik. So
Yeah,
so
good enough.
Vishal, why don't you talk them through it? So it's still a lot of people have trepidation with this.
so again, the Sapera, like PK said, the most important thing is to prep the lesion first.
Vishal, did you unlock the first one?
Yeah, it is unlocked.
Yeah, because it's not going forward.
I know, that's what I'm trying to see. There's so much tension in the system. No. No, it's unlocked. Give me another one. No, it won't pop
That's
up.
strange. Yeah, because it's
All right,
not
let's
moving at all.
150.
Yeah, I know. That's what I was
Let's see
trying to say.
whether let's walk it out. Let's lock it so this way it doesn't come off. So I'll lock it. You know, listen.
Yeah, I wonder if it's getting locked up at the iliac bifurcation.
Iliac bifurcation. Yeah.
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 Okay.
It
I don't
probably
think so.
kinked or
There's not.
No, but the mechanism is.
There's not a lot of
it's not-
tension, guys.
no, what Raman is saying is it must have kinked at the bifurcation.
Yeah.
That's what he's saying.
Yeah, but it went through up and easy.
Without a
whereas-
problem. Let me try to
Yeah,
deploy
yeah.
it here.
Okay, we can try to do it here if you want. Go.
Oh,
You zoom in.
No,
Nope.
can't do it outside
It's
the body.
defective.
Uh-oh.
What's
We
the
gotta put
odds?
this-
What's the odds, Vishal? What's the
We
odds?
need to put that in the
I've never
box.
seen a Sapera not deploy yet in the last 9 years. So that's the odd.
So what we're going to
I
do
mean,
now
that's
is,
a good problem to figure out
Yeah.
outside the body.
thank God, right? So we're going to go ahead and send that back to Abbott. And if this one doesn't deploy, then we're going to have probably a batch issue. Who knows? So what we'll do is we'll go ahead and have, we'll get a Zilver ready, guys.
Yeah,
And then we'll-
Abbott needs to fix this problem with deployment
know.
of Sapera. They need to come up with a much easier deployment.
Push this wire
If
down
it
a
gets
little bit
stuck in the middle, this stent can really expand. Like it can elongate
Okay,
crazily.
good, good. Okay, so we're going to start here with the Sapera, and I
Take
think we'll be
two.
fine with this one. Take two, exactly. That's a good spot.
So same thing
Vishal
first.
unlocked it. I see it.
I
Now
heard
it's
it.
moving.
It's moving.
No. No, that's,
There it goes.
There it is.
you know. Wow.
It's a lot of difficulty deploying it. I'm
I know it's a lot of
surprised.
tension in the system, which
Is
could
your
be because
sheath
of-
still where it was?
Yeah,
you
I
want to
think
change
is.
it? You want to change it to an 018 wire?
You can't change it now because you can't pull it out.
Yeah.
Remember, I did that live in Arch. I pulled out the
Yeah.
wire and we had to deploy the Sapera without a wire. So, yeah, something's happened. Karthik reminds me of everything at the right time.
Oh, wow.
It reminds me of all my mistakes.
Never.
Yeah, so the funny story is we're in Arch and Karthik and I were deploying the Sapera. And so they, for some reason, they asked me to do it. So I did it.
I
And
was
what
telling
happened
him not to
was,
take the wire out.
he said, don't
Yeah.
take out the wire.
And
And I
he
said,
pulled
oh,
it
we
out.
need an 018. So I pulled it out. And then the new Sapera, you can't put the wire back in. So
Yeah.
we just had to deploy it without a wire.
But you can do it for the newer ones. Speak in the last couple of months, I have seen that some of the operators have been doing it.
Oh,
They've
really?
been putting
Okay.
it in. I think unless they may change the lumen of the Sapera to take it in.
So you know that in this area it's going to deploy well because this is an area there's not much calcium. So we prep with a 7. So as Vishal gets closer to the calcium, he's going to start to try to be a little more judicious in terms of how he deploys it. For those of you who were at the symposium last month or last week,
Yeah.
excuse me,
Yeah.
you saw Metzger tried to deploy.
Oh, you see
Sapera
that?
in a
Yeah.
very
No,
difficult lesion.
a lot of the fellows asked me
was 3
after
days
he
ago.
deployed it. They asked me like the stent was so like prolapsed. They said like there was so much protrusion of the stent into the stent, prolapse. I mean, they were asking me like, how does it work? So I told the fellows all the time, like if you come back to this, as long as you get a good expansion, if you come back to this stent after a month, the stent
Correct.
completely just
Yeah.
self-adjusts itself and comes back to a regular stent size.
The only time I've ever seen it not adjust back to normal size was actually if you prolapse too much. So
Yeah.
if you like stack to the point where you've actually have infolded, that's the only time I've ever seen it not
But yeah.
come back to
But
its
remember-
normal predestined length.
Correct. And Metzger
And
actually did an
configuration.
IVUS post stent, and he could see how much circumferential gain was there in the first
Yeah.
case, if you remember that. Even though it
So-
looked ugly,
Yep.
but the from lumen inside was pretty much as round as it could get for the amount of lesion he had.
So I want you guys to look at how nicely this is deploying because of our vessel prep. Now you're in the heavily
definitely.
calcified segment, and now you can see Vishal is, of course, he is deploying it perfectly. And you can see, of course, there's a resistance. I'm sure he's feeling it in his hands, and he's being very judicious. But you can see how the stent is nicely deploying, and we are going to post dilate with that Viatrack, especially distally, and kind of hit the whole thing. But we'll do so. What our plan will be is we'll do an IVUS, we'll do a couple of CO2 shots. And then we'll come off air.
Yeah,
and
for
then-
a 6.0 stent to deploy this way, it's really nice actually. I mean, it looks fantastic.
So hopefully it doesn't foreshorten too much. You have to be careful because of the proximal. You
No,
do
it looks
want
like
it to be one.
looks like he's ending okay. He's ending at 25. So
That's 20 right there. So we got a long way to go. You're absolutely right.
no,
but
I'm
it's
saying yeah, I think it's nicely deployed. Very nice.
Yeah, look at that. It's perfect, actually. It's and you can see if you draw, you can draw 2 lines on the sides of the Sapera, sort of like a train track. And there's 25 right there for his. And it's important to get your target in line when you deploy these stents.
I would compress a little bit here, Vishal. You're ending much above 25.
Yeah.
So let's see. I mean, I always get surprised, and this is the problem with Sapera. I wish we knew. Of course, he's deploying it really, really well, but the question is, how much is it really going to elongate? Unless they made a 200 Sapera for us today and gave it to us, So it's okay if it goes a little bit over. I don't think it's a bad thing. So let's see. I mean, it's definitely not elongating. So he'll just go ahead and now compress a little bit. There you go. That's beautiful. That's compressing.
That was good.
You want to pull the camera up a little bit, Vishal, see where it's ending? Then you can... Yeah, you are really going way high, so I think you should compress it here.
Yeah,
You're going to end up somewhere in 30, so...
Yeah, it's like that, just like that. Yep.
Yeah.
Just stack it.
That's like
Now the other question is, would you have? I agree, bigger is better, but would you have considered a 5.5?
No, I think I think 6.0 is very good. I think he used a 7.0 balloon. Now you can deploy normally, Vishal. I think it's okay. It's compressed a lot.
Yeah.
Because a 5.5 would have deployed smoothly.
Pull back a little bit, Vishal. Pull back a little bit.
So now the nice thing is Vishal's going to pull with the left hand to extend the stent a little bit. Pull without deploying. Yeah. Without deploying, there you go. That's good. Now just keep pulling negative now. And then he's going to try to land it at 25, which I think he's going to be just short, but that's okay. A little short, a little bit more. That's as good.
You can pull now here. You can without unlocking. You can pull Vishal a little bit. It should be fine.
But it's gonna get stuck.
No, it won't. It will just take the whole stent up because he's just stacked so much.
There's too much calcium. I think you're just gonna end up.
Perfect. Good.
That's it.
Right at 25. Nice job. Save that. Okay, now give us the IVUS.
You wanna go with the Vitrac? Try to clean up that proximal part a little bit.
I think so. I think we'll do that offline for now.
Yeah,
I just want to show the Sapera, and then look at the lumen, and then we'll sign off. We'll do two shots, and then we'll have
the best part is stent always. Sapera always makes the vessel look good. So yeah, that's the best part about Sapera. So
we're going in with the IVUS. We're about 5 minutes over now. I apologize.
So PK, as you said, the surveillance. How do you do ultrasound surveillance, Brahman? How do you do it in your practice?
6 months, but is it one month afterwards, 6 months, and then yearly afterwards. And I'll do arterial duplex, ABI. I try in all my offices to do a full ABI with exercise. Because personally, I don't feel as if you get the same answers.
Show us the IVUS on screen.
IVUS screen.
Straight ABI, PVRs.
IVUS on screen, please.
Really get a good answer.
IVUS on screen, please.
Maybe a little bit challenging if he's not able to walk with the missing toes and everything.
Here's the IVUS for the IVUS, yeah.
Very nice.
There's a little bit of expansion needs to be done there. Flora?
Yeah. But overall, it looks great.
Do we have a 7.0 that BD balloon that's 014 balloon
Highlander.
or no? Highlander. Do we have that Highlander 7.0? Yeah. I don't think so, right?
I think they have a 6. I don't know if they have a 7.0. We can check on that.
Vishal and PK, do you guys do ultrasound before 6 months or?
Yeah, so say 1 month, 6 months, yeah.
Yeah, I mean, I tried it. With this gentleman, I'll do it at 1 month, and then 3 months, and then 6 months, and then a year.
Okay.
Yep.
Yeah, I used to do 6 months too, Raman, but I started doing 3 months on especially long segment if I do DCB and leave them, just to see the recoil, just so that I can.
You'll do 1, 3, 6.
No, I do just 1, 3 months, and then if it looks good, I just do it yearly. If the recoil happens, it happens in the first 3 months, and I just let it be, so that I can decide. Otherwise, I just do it yearly, based on the symptoms of the patient. Yeah, because if I see DCB recoil, then I do a lot of DCB. So if I do DCB recoil, it looks very good.
Yeah. So we're done now. So we're going to go offline now, and I want to thank you guys for the wonderful conversation, especially everybody at home, because now we're at 9:10. So I want to, for the sake of your time and our time, we're going to sign off. I just want to tell everybody what we're going to do. We're going to go ahead and do Highlander 7.0. Is it a Highlander? Or no, some other ultra something.
Ultraverse.
And then we're going to go ahead and balloon this with this balloon, and then we're going to expand the stent, and I think we're going to be done here, and then we're going to close up, and we're going to do exactly what Karthik said, and Raman, which he will be on aspirin and 2.5 of Plavix and 2.5 of rivaroxaban. Actually, he's on Eliquis. He's on Eliquis. Yeah, so it's not the same data.
So he's currently on Brilinta, if I remember correctly. So are we going to keep him on Brilinta, or would you keep
I believe we are, as you know, even though Euclid doesn't support it. In our practice, obviously our coronary interventionalist with Dr. Sharma, he's done obviously a lot of work on him. So therefore, if that's what the coronary people want, we will keep him on that, and then we will obviously follow him closely. And then as soon as the coronary people say no mas with the Brilinta, we'll go ahead and remove it, and then we'll continue with aspirin and this. So this is what you were talking about, Karthik. It's just a 7.0 balloon down, just to kind of touch up the stent a little bit. And I think with this we've got great flow. We're done. I think it's a great demonstration of really no dye, other than the groin shot that I had a brain, and then took that picture. So therefore, I think this is a good picture. We're not going to use any more contrast. It was going to be a manual groin hold here, and I think we'll continue our hydration. And I think the patient will do well.
Great. Yeah. Great case. Okay. Great case, Vishal.
Thank you, guys. And we're going to sign off here. And you guys go ahead and do the rest over there. So thank you, everyone.
All right, guys. So once again, thank you all very, very much for joining us today from Mount Sinai for this excellent live case and demonstration of a contrast-free intervention. And we look forward to joining you next month at the last Wednesday of October. On October, what is the date? October 25th. We look forward to seeing you soon. Take care.